Welcome to the second lecture on renal physiology, and today we will talk about kidney's role in maintenance of homeostasis. But before we will begin, I would like to show you this quote. In the last analysis, the composition of the plasma is determined not by what the body ingests, but by what the kidney decides to retain and what do they excrete. And this sentence by renal physiologist Homer Smith nicely describes what the kidney will do for the composition of plasma and for the substances which will remain in the body. And here you can see the questions which we will discuss. We will begin with neural and humoral control of the urine formation. Then we will talk about micturition, mechanisms, and reflex control. And the final part will be on role of kidneys in the regulation of arterial blood pressure. That would be the main focus of today's lecture. Blood osmotic pressure, extracellular fluid volume, ionic composition, and blood pH. These are the main parameters of the body that are controlled by kidneys. So before we will begin, here you can see the overview of the anatomy, a little bit of it. And as for the micturition reflex, here you can see it could be defined as the discharge of urine from the urinary bladder, and the synonyms which could be used: micturition, urination, or voiding. And renal excretion of water is referred to as diuresis. So that's basically the amount of water which is excreted by kidney. And micturition reflex, it occurs via a combination of involuntary and voluntary muscle contractions. So here you have two types of control. And lack of a voluntary control over the micturition is called urinary incontinence. Here basically you can see the structure of the urinary bladder. So, few things to be noted about micturition. The desire to urinate is stimulated by the distension of the bladder, and this will happen when the bladder is filled up to about 150 milliliters of urine. Urine volume approximately on average ranges around 300 milliliters or more. In this case, it will lead to sensation of uncomfortable fullness. This is where actually you will feel that the urinary bladder is full. And at maximum capacity of the bladder, which it may hold, is about like half a liter of urine. And following urination, less than 10 milliliters of the urine usually should remain in the urinary bladder. Here you can see the scheme of regulation for the micturition. So what do we have? How this reflex actually occurs? When there will be accumulation of fluid in the urinary bladder, it will lead to expansion of the wall, which will activate the stretch receptors. Then impulses will be sent from these receptors to the spinal cord, and what will happen? There will be reduced sympathetic activity, which will cause relaxation of the internal urethral sphincter and opening of it. Then there will be activation of the parasympathetic nervous system, which causes contraction of the detrusor muscle. And there will be reduced somatic motor neuron activity, which leads to relaxation of external urethral sphincter and opening of it. And all collectively it leads to micturition. So as you can see from this scheme, for the successful micturition to occur, you have to open the internal sphincter, the external sphincter, plus you need to contract the detrusor muscle. And also you can see how these three are controlled. So basically, involuntary centers you will have within the spinal cord. At the lumbar region, that's the sympathetic efferents, which will be inhibited in case of micturition, and the parasympathetic, which will be in sacral region. They are activated for the detrusor muscle to contract. And as you can see, and a slight reminder on the reflex regulation, afferent fibers, as you can see from the stretch receptors with the first sensory neuron at the ganglia, and efferent fibers, they will have two neuron structure as it belongs to the ANS. The first neuron will be in the lateral region of the spinal cord, and then if it's sympathetic, you will have rather short preganglionic fiber. The ganglia, here it's hypogastric ganglia, and rather long postganglionic fibers. In case of parasympathetic, it will be long preganglionic fibers, then intramural ganglia, and rather short postganglionic fibers. Plus, since these are for the involuntary control, and for the voluntary one, we have the brain cortex, which will control the external urethral sphincter through the anterior horns, where you have the motor neuron, which controls the external sphincter. So here, that's the reflex arc, the way it looks like for the voluntary and involuntary control, and this is the scheme which describes micturition. Now, here on this slide, you have a summary on mechanisms of regulation. So what do you have here? You have nervous control, which happens through the ANS. Then you have humoral control, which happens through biologically active substances, hormones mostly. And what can be noted from this scheme, the parameters which will be regulated, there will be filtration. Basically, here you might change the GFR and renal plasma flow, reabsorption, and secretion. If we are talking about nervous control of the kidney, then mostly it will be about sympathetic nervous system, which will mainly influence the renal blood flow, glomerular filtration, and also partially it might be mediated by renin-angiotensin system, which is basically the humoral one. As for the humoral control, here you can see main hormones which might act on kidney, and these hormones, they mostly influence reabsorption and secretion. So now we will talk in details about each of these controls. But before that, let me remind you a few things about the way GFR might be changed. So how can we change the glomerular filtration rate? First, you need to recall how do we count the glomerular filtration rate, which depends on net filtration pressure. For that, three pressures will be required. The first one, the glomerular capillary blood pressure, which will be around 60-65. And here you can see this is the force which actually favors the filtration. So that's the only force which will favor filtration in renal glomeruli. And you will have two forces opposing filtration. That would be the fluid pressure in Bowman's capsule space, so basically hydrostatic pressure in the Bowman's capsule, and that's the force, which is around 15 millimeters of mercury, and also osmotic pressure or colloid osmotic pressure created by plasma proteins. And this force is also opposing filtration, and it ranges from 25 to 30 millimeters of mercury. So this is the formula which is used to count the net glomerular filtration pressure. And this is the resulting value if you take the values as following. So now, how can you change the glomerular filtration rate? What can happen is constriction of the afferent arteriole, which could be achieved through sympathetic nervous system, which might activate alpha-1 receptors. And if you constrict afferent arteriole, the blood flow through the glomeruli will significantly decrease, which will decrease the hydrostatic pressure and will decrease the glomerular filtration rate. Now, if you will dilate efferent arteriole, which means you will reduce resistance in the glomerulus, and this will decrease the glomerular filtration pressure and the glomerular filtration rate. And the opposite is also true. If you will dilate afferent arteriole, which means you increase the blood flow through the glomeruli, and as such you increase glomerular capillary blood pressure and glomerular filtration rate. Or what could be done, you can constrict efferent arteriole for example, through low levels of angiotensin 2, and due to the constriction, you increase resistance, and because of that, there will be rise in glomerulocapillary blood pressure, which will increase the glomerular filtration rate. So why do we have all of these possible variations? Because it is extremely important for the kidney to keep the healthy GFR at the appropriate level, because it is essential for the excretion of salt, water, waste products, because all of these, it strongly depends on the glomerular filtration rate. And because of these, in kidney, there are nicely developed mechanisms of autoregulation, because they are meant to protect the glomerular capillaries from, on one hand, hypertensive damage, and on another hand, to preserve a healthy GFR if, for example, systemic blood pressure drops. And changes in glomerular filtration rate and renal blood flow are blunted by autoregulation. And here you have two options. One of them is myogenic response, and another one is tubuloglomerular feedback. So let me remind you the structure of juxtaglomerular apparatus. Juxtaglomerular apparatus consists of the granular cells, also called juxtaglomerular cells, so here you can see them, which are differentiated smooth muscle cells in the walls of the afferent arteriole. So basically, you can see they surround the afferent arteriole kind of like a cuff, so they can sense the fluctuations in the blood flow through the afferent arteriole. And secretion of renin happens in here. Also, you have macula densa cells. Here they are. And extraglomerular mesangial cells. That's the way they're located. So basically, that's what you need to know about the juxtaglomerular apparatus. So the first mechanism of the regulation which we will be discussing is the myogenic response. As you can understand from the name itself, myogenic, that's the one which is referred to the muscle. And myogenic response, it will be the result of direct reaction of the vascular smooth muscle to stretch or relaxation. But in most of the cases, we will talk about the stretching of the smooth muscle cells. And it is related to intrinsic property of the smooth muscles to contract if they're being stretched. So what happens in this case? When mean arterial pressure increases, there will be stretching of the smooth muscle in afferent arterial wall, which will stimulate to vasoconstriction. So in this case, rise in driving pressure is counteracted by a rise in vascular resistance. That would be almost offset the rise in pressure. And as such, it protects the glomeruli from short-term fluctuations in blood pressure. And also it keeps changes in renal blood flow and glomerular filtration rate very small. And what's the mechanism behind this? It will be because of the calcium ion influx. Stretch receptors in renal arterioles, they will detect rising pressures and cause the contraction of the afferent arterioles to increase resistance and maintain constant blood flow. So this is the myogenic response. The second case which we have, it's the tubuloglomerular feedback or intrarenal processes. So here you can see the scheme of tubuloglomerular feedback. So what do we have? Here is the case of decreased glomerular filtration rate. If there will be a drop in glomerular filtration rate, as such, flow through the tubule will decrease. And flow past macula densa will also decrease. And what will happen? Macula densa cells, they will detect that less sodium ions flow through macula densa, because this is what it can sense. And because of that, paracrine activity of macula densa cells will happen, and the substances which they will secrete, they will affect the afferent arteriole, leading to its dilation. On another hand, because of the macula densa cell related to juxtaglomerular apparatus, there will be renin release, which will eventually cause to angiotensin II formation, which will cause the constriction of efferent arteriole. So these two events, dilation of the afferent arteriole, as you remember, and constriction of the efferent arteriole, these two together, they will help to successfully rise the hydrostatic pressure in the glomerulus, which will bring the glomerular filtration rate back to the normal level. So basically, we neutralized the drop of the glomerular filtration rate. And as it comes from the name, it is feedback from the tubules back to the glomerulus. And as we said, effiltration rate in individual nephron will increase and decrease the amount of sodium which escapes reabsorption in the proximal tubule, and the loop of Henle also will change, and this is what will be detected by macula densa cells, because that's what they sense, the amount of sodium and chloride in the lumen. They are the salt detectors, so that's the point of the scheme. And there will be secretion of transmitter agents, paracrine secretion, which will change the lumen of the afferent arteriole, so that there will be right amount of the sodium remaining in the lumen to flow past the macula densa. So basically, this is the tubular glomerular feedback, which helps to control the GFR. And this is example of the local regulation. Here, you can also have a second look at tubular glomerular feedback, a brief summary. So macula densa cells, as we already discussed, they respond to changes in sodium chloride concentration in the filtrate in the distal convoluted tubule. And if there will be decreased concentration of sodium chloride concentration, it will lead to afferent arteriole vasodilation. And vasodilation of the afferent arteriole results in the following. You will have increased blood flow in the glomerular capillaries, plus there will be increased glomerular filtration pressure, and there will be increased GFR. And of course, the opposite is also true. Now, this graph you might have seen, this is what is called autoregulation of renal blood flow and glomerular filtration rate. On x-axis, you can see the mean arterial blood pressure values. And as you can see, the glomerular filtration rate is kept relatively constant despite fluctuations in mean arterial blood pressure. So on average, if fluctuations are kept within from 60 to 180 millimeters of mercury, blood flow to the kidney remains normal, even though the fluctuation range is more than 100, which helps to maintain normal glomerular filtration rate. So basically, this is the zone of autoregulation. And those two mechanisms which we have discussed, myogenic response and tubular glomerular feedback, they're meant to provide this autoregulation of renal blood flow and glomerular filtration rate. Now here on this slide, you can see some of the hormones which regulate tubular reabsorption. And examples are aldosterone, angiotensin II, antidiuretic hormone, atrial natriuretic peptide, parathyroid hormone. These are not all of them, but some, and here you can see there is a side of action for these hormones and the effects which they will produce. And we will talk about these hormones in details a little bit later on. Now, here on this scheme, you can see basically a summary on steps of urine formation, which include glomerular filtration, which is the first step. Then you will have obligatory reabsorption and secretion in proximal convoluted tubule. And then you have osmotic concentration of urine in tubular system. That's what we did in last lecture. That was the countercurrent mechanism. Then there is facultative reabsorption and secretion in distal convoluted tubule. That leads to final concentration of urine in collecting ducts and urine excretion, followed by micturition or voiding of the urine. And what we have, which parameters could be regulated through the urine formation. We can regulate osmotic pressure, pH, CO2, then concentration of various nutritive substances, including glucose, temperature, and blood pressure. So we will begin our discussion with control of salt and water excretion. And here you can see there are three main outcomes of the water control and salt control. It will help to maintain the body fluid volume, it will help to maintain an osmolality of the fluid, and it helps to maintain the arterial blood pressure. And there is such 60-40-20 rule, which helps you to remember how much of the fluid do we have in the body. The rule is quite simple. So what do we have in here? Total body water in liters is about 60% of body weight in kg, that's for adults. Intracellular fluid volume is about 40% of the body weight, and extracellular fluid is about 20% of body weight. So here you can see 60-40-20 rule. 60 comes to the total body water, then 40 it's the ICF, and 20 is the ECF. Here at this scheme, you can see various body fluid compartments which we have. So as you can see, here you have female versus male. That's the amount of solids that we have, and the fluids, as we said, 60 around. Then these fluids, the total body fluid, will be divided into intracellular and extracellular fluid, 60-40-20 rule. Then extracellular fluid is further subdivided into interstitial fluid, which is about 80%, and 20% of the plasma. That's the distribution. And beside that, other types of extracellular or interstitial fluids, they include lymph. Also, we have transcellular fluids like cerebrospinal fluid, synovial fluid, aqueous humor, endolymph, perilymph, pleural, pericardial, and other fluids between serous membranes. Now, what are the sources of daily water gain and water loss under normal conditions? So here you can see the summary on water gain and water loss. If approximately we're talking about 2 liters. So as for the water gain, mostly it will be through ingestion of liquids around 1.5 liters. Also ingestion of various types of food, and small amount of metabolic water is produced. What about water losses? As you can see, most of it will be lost by kidney. Then certain amounts are lost through the skin like sweating, but this amount definitely depends on environmental conditions and temperature. Then small amounts are also lost through the lungs and the GI tract. So as you can see, normally the body fluid volume remains relatively constant because, as it comes from this slide, water loss is approximately equal to the water gain. But if it's not true, then dehydration might occur. This is when water loss is greater than the water gain. And some of the examples, they include strenuous exercises, diarrhea, for example, during GI tract infection, then vomiting, and beside dehydration, hyperhydration might also occur. This is when water gain is greater than the water loss. And some of the examples, they include consuming too much of water, intravenous fluids are given but not balanced in composition to match the fluid and electrolyte loss. Now, before we'll talk about water and electrolyte balance, there are a few things which you should know. Fluid shifts between compartments, they follow several basic principles. Intracellular and extracellular fluids are in osmotic equilibrium, which means they have same osmotic pressure. Now, let me remind you that sodium is one of the major cation of the extracellular fluid, while potassium is the major cation of the intracellular fluid. The distribution of sodium and potassium is maintained by sodium-potassium pump or sodium-potassium ATPase, which, as you might remember from excitable tissues, pumps out the sodium and pumps in potassium. And equilibrium between the intra and extracellular fluid occurs through water movement not through the movement of osmotically active particles. So their concentration basically remains the same. It's the water which moves. And fluids, they move across cell membrane only because of osmolarity differences. So if osmotic gradient changes, movement of water will occur. So here you can see the first example if dehydration will happen. So once again, normally with all the fluid volumes, they must remain constant because water gain is equal to the water loss. So dehydration occurs if water loss is greater than the water gain. And here are the examples. Now, let me remind you the osmotic pressure definition. That's the precise amount of pressure required to prevent the osmosis from happening. That's the osmotic pressure. And the concentration of osmotically active substance in a solution is called osmolality if it's expressed in kg, in osmoles per kg of water. And if we are talking about osmoles per liter, this is the osmolarity. But the difference between them is fairly small, so most of the times they will be used interchangeably. So let's take a look at the scheme which you have. Dehydration. If there will be increased water loss, it will lead to decreased flow of saliva, which leads to the sensation of dry mouth, and this successfully stimulates the thirst center in hypothalamus. Then dehydration also increases blood osmolarity, and it stimulates osmoreceptors, which will be also located in hypothalamus. And also, because water loss does not match the water gain, means there will be decreased blood volume, and as such there will be decreased blood pressure, which will activate the renin release and activation of renin-angiotensin-aldosterone system and angiotensin II formation. And because all of these, there will be increased thirst and increased water intake, which will compensate the water loss, and the water body fluid will become normal, which will relieve the dehydration. So basically, this is the summary of events which might occur during dehydration. Now, how hypothalamus regulates osmotic pressure and controls water in the body. Here you can see two situations. One is when there is low water intake, which is called dehydration, which might lead to dehydration, and high water intake, which might lead to hyperhydration. So in this case, in case of dehydration, there will be increased plasma osmolarity, which will stimulate osmoreceptors located in hypothalamus. And as you know, here you also have the cells which secrete the antidiuretic hormone, so its concentration will increase and it will be released by posterior pituitary into the blood. Antidiuretic hormone will go to the kidney and it will stimulate water reabsorption by kidney, and as such less water is excreted in urine, so basically water retention occurs. So that's the negative feedback correction. And the opposite is also true. If there will be high water intake, plasma osmolarity decreases, so osmoreceptors will not be stimulated and antidiuretic hormone will not be released by posterior pituitary. It will not reach kidney and there will be no water reabsorption. So more water is excreted with urine, and this is also called negative feedback correction. And here also we have few definitions. Anuria, abnormally low urine output. It will be considered if it's less than 50 ml per day. Oliguria, this is decreased urine output below 3 to 500 ml per day. And polyuria, the term which you might know from endocrine, this is excessive or abnormally large production of urine. The next question which we will be discussing, basically here you have comparison of two systems controlling effective circulating volume and osmolality. You have baroreceptor control and osmoreceptor control. Baroreceptor control, it will control the effective circulating volume. And sensors you will have in carotid sinus, aortic arch, This is where you have the reflexogenic zones with baroreceptors located. And efferent pathways, they will include both mechanisms, nervous through the sympathetic nervous system and humoral through renin-angiotensin system, through antidiuretic hormone and atrial natriuretic peptide. And the mechanisms will be divided into short-term and long-term. Short-term, that's the neural one. Effectors will be heart and blood vessels, contractility, heart rate, and total peripheral resistance. And for the long term, kidney excretion of electrolytes and water. And what is affected? The blood pressure for the long term and these effectors, and the long term, in most of the cases, sodium excretion. What about osmoreceptor control, plasma osmolarity, the one which we discussed right now? The receptors will be in hypothalamus, and these are the osmoreceptors. And there will be two mechanisms. One is through ADH, kidney and renal water excretion, and another one through thirst and brain drinking behavior, water intake. So, two major mechanisms. Now, let's take a closer look at short-term blood pressure control mechanisms, which include three effectors. It could be through chronotropic mechanism, inotropic mechanism, or through the vessels. So here you can see the summary on events. As you can see, if there are blood pressure changes, there will be either activation or inhibition of sympathetic and parasympathetic nervous system. And what will happen if, let's say, blood pressure decreases, then baroreceptors will not get stimulated and there will be redistribution of the activity of the brain stem centers, which control cardiovascular activity. And in that case, for example, if blood pressure is low, sympathetic nervous system activity will increase, which will cause increased total peripheral resistance or because of the vasoconstriction. This is the true vessel mechanism. Then it will increase contractility of the heart, that is the inotropic mechanism, and it will also increase the heart rate, which is the chronotropic mechanisms. Contractility and the heart rate, they control the stroke volume, which will affect the blood pressure, as well as total peripheral resistance contribute to the blood pressure as well. And if blood pressure is high, in that case, you have activation of parasympathetic mechanisms and reduced activity of the sympathetic nervous system. Now, what about the long-term blood pressure control, which includes, which is mostly based on hormones? Here you have brain-kidney interaction through natriuresis, which control the blood volume, and capacity of the vascular bed, which might control the venous return and stroke volume because of that, and contribute to the blood pressure, as we have mentioned before. And also we have total peripheral resistance and contractility, which also contribute to the blood pressure control. And basically, the long-term blood pressure control is based on the control of the blood volume. And here on this scheme, you can see the summary of mechanisms related to the timeline. You can see we have seconds, we have minutes, we have hours, and we have days. So as you can see, those mechanisms which will be quite quickly activated, they are the chemoreceptor, baroreceptor control plus the nervous system activation. So these are those immediate mechanisms which are activated very quickly. As for the stress, renin-angiotensin, vasoconstriction, and capillary fluid shift, they are rather prolonged, like minutes to hours. And renal fluid volume pressure control, it will be delayed. It happens after a few hours. And as you can see, the aldosterone mechanism, it's one of the latest one which will contribute to the blood pressure control. So that's how they're related in time and short-term and long-term mechanisms. As you can see, short-term, they are the neural ones, and long-term, they are the humoral ones. Now, let's talk about another feedback control if there will be increased intake of the sodium chloride, increased salt intake. In this case, you can see there will be increased plasma concentration of sodium chloride, and as such, there will be increased osmosis of water from intracellular fluid to interstitial fluid of plasma, which will lead to increased blood volume. And because of that, increased atrial stretching, which lead to increased release of atrial natriuretic peptide, which will reduce reabsorption of sodium by kidney, and natriuresis happened. On the other hand, there will be inhibition of renin-angiotensin-aldosterone system, which will increase glomerular filtration rate and decrease the release of aldosterone, which is the antagonist of natriuretic peptide. And all of these will lead to increased loss of water in urine by osmosis. This is what is called natriuresis, and decreased blood volume. So basically, you reverse the changes which happened initially. So it's meant to eliminate the excess of body water or solids, and the control is mainly provided by the loss in urine. And the extent of urinary salt loss that's the main factor which determines body fluid volume. And the reason is that water follows solids, and osmosis, that's the base of it. And sodium and chloride, they are two main ions which are present in extracellular fluid. So the main factor which determines the body fluid osmolarity is the extent of urinary water loss. Now, here you have the summary of factors which maintain the body water balance. So here you can see the factor, the mechanism by which it acts, and the effect which will happen. So one of the things which we already mentioned, it's about the thirst center in hypothalamus, which stimulates desire to drink fluids, and water gain happens if thirst is stimulated. Now, angiotensin 2, which stimulates secretion of aldosterone, reduces loss of water in urine. Aldosterone, the next hormone, it will promote reabsorption of sodium and chloride and increases water reabsorption by osmosis. So it will reduce loss of water in urine. And with its antagonist, which is the atrial natriuretic peptide, which promotes natriuresis, which is due to the increased urinary excretion of sodium chloride accompanied by water loss. So increased water loss in urine. And antidiuretic hormone, it is also known as vasopressin. It will, what's the mechanism of action, actually, which we didn't mention before? It helps to create water channel proteins, aquaporin II, into the apical membranes of the principal cells in the collecting ducts of the kidney, principal cells we have mentioned during the previous lecture. And as such, it increases water permeability of these cells, and more water is reabsorbed. In absence of ADH, there will be no aquaporins, so water could not be reabsorbed. And one of the situations which also have to discuss is the water intoxication. Water intoxication, it might occur if there will be excessive fluid loss, like during sweating or vomiting or diarrhea, which is coupled with intake of plain water, like tap water, which is not basically balanced in electrolyte. This will lead to decreased sodium concentration of interstitial fluid and plasma, which is called hyponatremia, and decreased osmolarity of interstitial fluid and plasma, and osmosis of water from interstitial fluid into intracellular fluid. And water intoxication will occur, cells will swell, and clinically it might manifest through convulsions, coma, and might possibly lead to death. Now, we already have mentioned a couple of times renin-angiotensin-aldosterone system. So here you can have a summary of factors influencing renin secretion. You can see those which are inhibiting or stimulating factors. So you have increased sodium chloride, reabsorption, which passes through macula densa, then afferent arteriolar pressure, angiotensin second itself, vasopressin, sympathetic nervous system activity, increased circulation of catecholamines, which is basically the mediator of the sympathetic nervous system, and prostaglandins. Now, this is one of the schemes which you might come across if you will try to Google the renin-angiotensin-aldosterone system. And here you can see the pathways and how this system might be activated. So, for example, if there is dehydration or sodium deficiency or hemorrhage, which will lead to decreased sodium chloride delivery past maculodensa cells, and decrease in blood volume, which leads to decrease in blood pressure and decreased perfusion of kidney. In this case, kidney will start secreting renin, which will convert the angiotensinogen, which comes from the liver, into angiotensin 1. Angiotensin 1 in lungs will be converted with the help of angiotensin converting enzyme into angiotensin 2. And this is the substance which will do some of the effects. What do we have? Vasoconstriction of arterioles, which will increase the total peripheral resistance, and as such it increases blood pressure and it returns to normal, and that's what we begin with. Then it also acts on the cortex of the suprarenal gland to release aldosterone, and aldosterone, it will increase sodium and water reabsorption through osmosis, and there will be increased blood volume, which also increases the blood pressure. So that's a summary. And one of the most commonly seen diagrams is also as follows. So basically the beginning is pretty much the same. You can see decreased in perfusion activates the system with the final substance which we're talking about is angiotensin 2. And as we have mentioned, there will be aldosterone secretion with angiotensin 2 itself. It causes reabsorption of sodium and water retention, which increases the cardiac output and ECF volume and increases the blood pressure. Then angiotensin 2, it's a very powerful vasoconstricting substance which increases total peripheral resistance and the blood pressure, and also same effect will be achieved through the activation of sympathetic nervous system activity. Plus, it stimulates ADH secretion, which also causes a water retention. So all of these effects together, they will help to increase the blood pressure and to return the renal perfusion back to the normal level. Here you have a summary on regulation of the kidney. Two main mechanisms there will be, neural and humoral control, as we have mentioned. Plus, all these mechanisms, they could be divided into intrinsic or local regulation, which could be achieved through the myogenic response. That's the example of autoregulation. And as we have mentioned, if there will be increased or decreased blood pressure, stretching or not stretching of smooth muscles, it will lead to vasoconstriction or vasodilation to maintain healthy GFR. Another example of the intrinsic control or autoregulation, that's the tubulo-glomerular feedback mechanism. And here you have a summary with the example of maculodensa cells and its paracrine activity, which leads to vasodilation of afferent arteriole. And extrinsic mechanisms, they will be divided into neural control and humoral control. Neural control is mostly by activation of the sympathetic nervous system due to the baroreceptors located in blood vessels. And humoral control, it is mostly based on renin-angiotensin-aldosterone system, which we have discussed just now, recently. And now let's have a summary on factors which regulate the blood pressure. So this scheme is kind of as complete as it could be. So as we already mentioned, normal blood pressure is controlled by cardiac output and the total peripheral resistance, and is dependent on the heart and blood vessels, as well as extracellular volume, kidneys activity, nervous system, humoral factors, and cellular events of the membrane within the cell. This is what you have in this scheme. Cardiac output, in turn, is determined by the stroke volume and heart rate. And stroke volume, it depends on intravascular volume, which is regulated by the kidneys, as well as on myocardial contractility. Remember, we have mentioned inotropic effect. And myocardial contractility involves sympathetic and parasympathetic control of the heart rate, intrinsic activity of the cardiac conductive system, and complex membrane transport and cellular events, which require influx of the calcium as the main ion, which is essential for the contraction. And it leads to myocardial fiber shortening and relaxation. And also is regulated by humoral substances, for example, like catecholamines, which stimulate the heart rate and myocardial contraction. Total peripheral resistance is regulated by baroreflexes. So here you can see the reflexogenic zones, which you have discussed in cardiovascular system. And these baroreflexes and sympathetic nervous system activity, its response to neurohumoral substances and endothelial factors, plus myogenic responses and intracellular events mediated by receptors and mechanisms for other signals transduction. Now, baroreflexes will be derived from high-pressure baroreceptors in aortic arch and carotid sinus, and also low-pressure cardiopulmonary baroreceptors in ventricles and atria. Aortic baroreceptor nerve fibers, they travel via the vagus nerve, which is the cranial nerve number 10, and carotid sinus fibers, which travel via the glossopharyngeal nerve, which is the cranial nerve number 9. And these receptors, they respond to stretch, high blood pressure, or filling pressure, low pressure, and they send tonic inhibitory signals to the brainstem. And if the blood pressure increases and tonic inhibition increases, then inhibition of sympathetic efferent outflow occurs, and which will decrease the vascular resistance and heart rate. However, if the blood pressure decreases, in that case, less tonic inhibition occurs, and the heart rate and peripheral vascular resistance will increase, thereby increasing the blood pressure. The brainstem cardiovascular centers, they are localized in the dorsal medulla. Here you can see the area which controls the cardiovascular center, dorsomedial medulla. And neural afferents from the cranial nerves, which is cranial nerve number 9 and 10, are integrated in the nucleus tractus solitarius. From here, vasoconstriction and increased heart rate are mediated through the caudal and rostral ventrolateral medulla by the sympathetic nervous system. And nucleus tractus solitarius sends efferent to communicate with the nucleus ambiguus, which is the vagal nuclei, to decrease the heart rate through the vagal influence. And also the central neural control of renal function will modulate the renal blood flow and glomerular filtration rate, which we mentioned before, and excretion of sodium and water and renin release. And these factors in turn, they will regulate intravascular volume and vascular resistance and the blood pressure. Inhibitory reflexes also originate in the kidney, increase in urine flow rate, and increase the renal pelvic pressure, which stretches the renal pelvic wall, leading to activation of mechanosensory nerves in the renal pelvic wall, and activation of these sensory nerves will decrease the renal sympathetic nerve activity and induce diuresis and natriuresis and inhibitory neurorenal reflex response. And the responsiveness of renal sensory nerves is modulated by dietary sodium intake. A high sodium intake enhances the responsiveness of the afferent renal mechanosensory nerves. So this is what we mentioned also. Later on, because the scheme is quite big, you can, if you will be rewatching the lecture, you can pause and read about the substances and the receptors which we have and their cellular effects in detail. And now just a brief overview, because we have numerous vasoactive substances which have effect on blood vessels, the heart, the kidney, and the central nervous system to regulate the blood pressure. One of them, as we mentioned, renin-angiotensin-aldosterone system, which regulate volume, peripheral vascular resistance, and we also have angiotensin 2 from the renin-angiotensin system, which constricts vascular smooth muscles and stimulates aldosterone secretion and potentiates the sympathetic nervous system activity and stimulates salt and water reabsorption in the proximal tubule, also stimulates prostaglandin, nitric oxide, and endothelin release, increases thirst, and stimulates vascular remodeling and inflammation. And also increased renal angiotensin activity has also been linked with salt-sensitive hypertension, even if there will be no volume expansion. So basically, this is the summary of main substances which control the blood pressure and extracellular fluid volume. Another system which deserves to be mentioned is kallikrein-kinin system. It counters the renin-angiotensin-aldosterone system and produces vasodilating kinins. One of them is bradykinin, which stimulate prostaglandin and nitric oxide production. For example, prostaglandin E and prostacyclin, they block the vasoconstriction by angiotensin II and norepinephrine. And two endothelium-derived factors have opposite effects on the blood vessels. Like nitric oxide is a vasodilator, whereas the endothelins are vasoconstrictors. And natriuretic peptide that includes, we have a few of them, which includes ethyl natriuretic peptide, brain natriuretic peptide. They induce vasodilation and natriuresis and inhibit other vasoconstrictors from renin-angiotensin-aldosterone system, and also sympathetic nervous system activity and endothelin. So here you have a summary and the interaction through angiotensin converting enzyme and kinase the second. And here you can see the effects which are mediated by different receptors for bradykinin, two types of receptors, and for angiotensin also two types of receptors and their effects. And here you have a small summary on kallikrein-kinin system. It is related to polypeptides such as bradykinin mostly, and overall this system plays a role in inflammation and blood pressure control, pain. Then functions will be vasodilation, secretion of prostaglandins like prostaglandin E2, decrease of vasoconstriction, opposing the effects of angiotensin II, and increase of vasodilation and diuretic effect of kinins. Now, we have mentioned a couple of times prostaglandins, that's one more system. They are derived from fatty acids, they are hormone-like substances, and some of the functions, they include vasodilation and decrease, for example, sodium transport in tubules, and because of that, decrease water reabsorption. And for prostaglandins, here you can see the summary on some of the effects which they might produce. Two prostaglandins which are most commonly mentioned, they are the prostaglandin E2 and prostaglandin I2. Now, the next question which we are going to discuss will be related to ions. And here you have some of the functions of ions in the body. Ions, they control the osmosis of water between fluid compartments, as we have mentioned already. They help to maintain the acid-base balance required for normal cellular activities. Then they also carry the electrical currents. This is what we have discussed in excitable tissues, which allow production of action potentials and gradient potentials. And also they serve as numerous cofactors needed for optimal activity of some enzymes. Some of these you might have mentioned during the digestion. Here you have a summary of distribution of ions across intracellular, extracellular fluids. So you can see in yellow, these are the intracellular fluid, and red is the blood distribution, and the blue one is interstitial fluid. So the main difference between the two extracellular fluids, blood plasma and interstitial fluid, blood plasma contains many proteins, as to maintain the oncotic pressure, and electrolyte content of the interstitial fluid differs from extracellular fluid. This scheme you might find more comfortable because here you can clearly see which ions are mostly found in extracellular fluid and which ions are mostly found in intracellular fluid. So, as we have mentioned before, sodium is mostly located outside the cell, as well as chloride, and potassium is mostly found within the cell, and also the rest of the ions and protein distribution. Now, we will have a brief overview on major ions which we have in the body. So, as for the sodium ions, 90% of the extracellular cations, normal blood plasma concentration, the range is given, and the function will be it provides osmolarity of the extracellular fluid and generation and conduction of action potential in neurons and muscle fibers. Kidneys excrete excess of sodium, but they also can conserve it, and level in blood is controlled by aldosterone and natriuretic peptide. And two conditions might happen. They're called hyponatremia and hypernatremia. Another ion which is related to sodium as well, chloride ions. They're also prevalent in extracellular fluid, and here you have the normal range in the plasma. They move relatively easy between intracellular and extracellular fluid, and they help to balance the level of anions in different fluid compartments. As an example, you might remember this is what we had in red blood cells, chloride shift between red blood cells and plasma, which happens in case of transport of CO2. And the same example you might have seen in hydrochloric acid secretion when gastric juice is produced. Antidiuretic hormone helps to regulate chloride balance because it controls the extent of water loss in urine, and increase or decrease of renal absorption of sodium might also affect the reabsorption of chloride because we have sodium chloride importers. And there are two possible deviations, hypochloremia and hyperchloremia. The next ion, potassium, is the major intracellular cation. And here you can see the normal plasma concentration. And potassium is important to establish the resting membrane potential, and it also plays very important role in repolarization phase of the action potential in excitable tissues like neuron, muscle, fibers. Then it also helps to maintain normal intracellular fluid volume. It helps to regulate blood pH because it moves into and out of the cell in exchange of hydrogen ion. And levels of potassium will be mainly controlled by aldosterone. Two possible deviations which might happen is hypokalemia and hyperkalemia. Now, why do we talk about potassium and why is it important to consider its levels in plasma? Because serious manifestations usually occur when the plasma potassium level rises more than 7. This is what is called hyperkalemia. And cardiac manifestations could be recorded through the ECG. On ECG, you will find a tall, peak, and symmetrical T wave. And this is the first change seen in ECG in patients with hyperkalemia. Because T wave, as you might remember, is related to repolarization of the ventricles. And that's why these changes will occur in hyperkalemia. Now here you can see the summary on plasma concentration of potassium, how it's being regulated. This is the feedback of aldosterone secretion. For example, if there is an increase in intake of potassium, plasma concentration of potassium increases, there will be aldosterone produced. It acts on kidney, and it will lead to potassium secretion, and cortical collecting tubules will be stimulated to secrete potassium, and it will be excreted with the urine so that the normal of potassium becomes normal. And on another side, you can have a scheme of sodium regulation, which involves aldosterone, GFR, and proximal reabsorption of sodium in proximal convoluted tubule. And here you have as a reminder how potassium will be filtered, reabsorbed, and secreted. These questions we discussed during the previous lecture, and here you have the potassium hydrogen exchanger, which is important for the pH regulation as well. Potassium handling, here you have a summary on factors which lead to increased potassium entering the cell, like insulin, stimulation of beta use of beta adrenergic agonists, and alkalosis, and factors which lead to cellular efflux of potassium, insulin deficiency, like in case of diabetes, beta adrenergic antagonists, acidosis, cell lysis, because as you know, potassium is found within the cell. If they've been massively destroyed, then potassium level in extracellular fluid will increase. Exercises and inhibitors of the sodium potassium pump, because now it will be no longer pumped into the cell. Now, the next one is bicarbonate ions. That's the second most prevalent extracellular anion, and normal blood plasma concentration is given, and exchange of chloride and bicarbonates, as we have mentioned, helps to maintain the correct balance of anions in intra and extracellular fluid. And of course, bicarbonates, they are important for the regulation of blood pH. And what do we have in kidney? We have intercalated cells of the renal tubule, which can either produce bicarbonates and release it into the blood when the blood level is low, or excrete excess of bicarbonates in the urine when the level in blood is too high, which is used for the pH regulation. Calcium ions, that's the major cation in interstitial fluid. Now, normal blood plasma concentration of free or unattached calcium is given, and about the same amount is attached to various plasma proteins, and almost the entire calcium in adults is located within the skeleton and teeth, combined with phosphates. And in body fluids, calcium is mainly an extracellular cation, and it contributes to the hardness of bones and teeth, but it also plays an important role in blood clotting. That's the factor number 4, and that's the factor which takes part in all the stages of coagulatory hemostasis. Then calcium is also essential for the neurotransmitter release. If you remember, it comes from ECF, and it activates vesicles to release the neurotransmitter into the cleft. Then it is also needed for the maintenance of muscle tone, because it's essential for the contraction. Obviously, it's needed for excitability of the nervous and muscle tissue. And the level of calcium will be controlled by parathyroid hormone, which increases bone resorption, reabsorption of calcium in kidneys, and absorption in GI tract. So these are the 3 target organs of parathyroid hormone. And with its antagonist, which is calcitonin, which is produced by the thyroid gland, parafollicular cells, which inhibit the activity of osteoclasts and accelerates the calcium deposition into bones, and thus lowers the blood calcium levels. And 2 possible deviations here: hypocalcemia and hypercalcemia. Now, phosphate ion, you can see most of the phosphate in adults will be present as calcium phosphate salts that are the structural components of the bone and teeth, and the remaining 15% will be ionized. Normal blood plasma concentration is given, and 3 phosphate ions which we have are important intracellular anions, and they are important buffer of hydrogen ions in both like body fluids and in urine as it will be excreted. Most phosphate ions are bound to organic molecules such as lipids, phospholipids, proteins, carbohydrates, DNA, RNA. And for the regulation, we have parathyroid hormone, which stimulates reabsorption of bone matrix by osteoclasts, which releases both phosphate and calcium ions into the bloodstream, but inhibits reabsorption of phosphate ion while stimulating reabsorption of calcium by renal tubular cells. And PTH inhibits phosphate reabsorption, causing phosphaturia, excess of phosphate in urine. And calcitriol, which is the active form of vitamin D, promotes absorption of both phosphate and calcium from the GI tract. And 2 possible deviations could be seen. Now, one of the ions which we don't really discuss much in class, but it doesn't mean that it's not important, it is. That's magnesium ions. It is also part of the bone matrix as magnesium salts, and also we have it as remaining as magnesium ions. This is the second most common intracellular cation, and here you have the normal plasma concentration. And why is it important? Because it's used as a cofactor for some enzymes needed for the metabolism of carbohydrates and proteins, and for the sodium-potassium pump functioning, and it's essential for normal neuromuscular activity, including the cardiomyocytes. Also, it is needed for synaptic transmission, myocardial functioning, and secretion of parathyroid hormone. It also depends on magnesium. Now, regulation of blood plasma level of magnesium varies. It depends on the rate with which it's excreted in urine. And magnesium and calcium, they compete for reabsorption in the thick ascending limb. And as you can see, kidney, they increase urinary excretion of magnesium in response of hypercalcemia, or hypercalcemia inhibits magnesium reabsorption. And here you can see the two possible deviations which might occur. The next question which we need to discuss is regulation of blood pH. As you might remember, blood pH shouldn't really change, and even slightest fluctuations, as you can see, they might be fatal. Two possible deviations could be seen: acidosis. This is when blood pH is below 7.35, and alkalosis. This is when blood pH is greater than 7.45. Few definitions. To remind you, an acid is a proton donor, which is a molecule or ion that can contribute hydrogen ion to a solution. A base is a proton acceptor, which is a molecule or ion that will combine with the hydrogen ion to remove it from the solution. Hydrogen is the acid, and A-, that's the conjugate base, and this equation, which is the acid-base pair. And the strength of an acid is defined with respect to the ease with which hydrogen could be released, and the strength of the base is defined with respect of how strongly it binds to hydrogen. So basically, in the body we have three mechanisms of hydrogen removal: buffer systems, which we discussed within the blood physiology, and buffers, they act quickly to temporarily bind hydrogen, removing the highly reactive excess of hydrogen from the solution. Second mechanism includes exhalation of carbon dioxide through the lungs. By increasing the rate and depth of breathing, more carbon dioxide can be exhaled, and within minutes this will reduce the level of carbonic acid in the blood, which raises the blood pH, which means reduces the blood hydrogen level. And last but not least, kidney excretion of hydrogen, the slowest mechanism, but the only way to eliminate acids other than carbonic acid is through the excretion through urine. So let me remind you the buffer systems. I hope you do remember this reaction. So buffer system consists of a weak acid and a salt of that acid, which functions as a base. Principal buffer systems of the body fluids are: we have protein buffer system and hemoglobin buffer. Hemoglobin buffer is the strongest buffer system in the body cells, and it's the intracellular buffer. Carbonic acid bicarbonate, this is the strongest buffer in extracellular fluid, and also we have phosphate buffer. So four buffer system: protein, hemoglobin, bicarbonate, and phosphate buffers. Now, here you have the example of negative feedback regulation of blood pH by the respiratory system through the excretion of CO2. So what do we have here? An increase in carbon dioxide concentration in the body fluid will increase hydrogen concentration, and thus lowers pH, which means it makes body fluids more acidic. And a decrease in carbon dioxide concentration of body fluids rises the pH, which means makes it more alkaline. And pH of body fluids and the rate of depth of respiration interact via the negative feedback loop. These two, they are related. And as you can see, expiration of CO2, it lowers the hydrogen concentration of blood because of the carbonic acid. So If, for example, there will be an increase in hydrogen concentration, which means blood pH becomes more acidic, in this case we have chemoreceptors. As you might remember, they are divided into central and peripheral, and they will send impulses to the respiratory center, stimulating the inspiratory area in the medulla. And from this respiratory center, impulses will be sent to the effectors. These are the inspiratory muscles, and activation of inspiratory muscles will cause activation of the forceful breathing, so that the more CO2 will be excreted as less carbonic acid remains in the blood, fewer hydrogen ions are present, and blood pH returns back to normal. So what are the possible deviations which might occur, since respiratory system, as one of the systems which contributes to the regulation of the pH, there could be respiratory acidosis, which is caused by hypoventilation, in which case there will be increased CO2 resulting in decreased pH and slight increase in bicarbonates. And respiratory acidosis could be diagnosed when partial pressure of CO2 is greater than 40. And the other one is respiratory alkalosis, which is caused by hyperventilation, where there is decreased CO2 levels, which will result in increased pH and a slight decrease in bicarbonates. And respiratory alkalosis is diagnosed when partial pressure of carbon dioxide is less than 40. And possible causes, they include hyperventilation and high altitude. Now, beside respiratory system, kidney, they also contribute to regulation of blood pH. And as you know, kidney, they're responsible for the excretion of waste products. So in this case, the person might have metabolic acidosis or metabolic alkalosis. What can happen in case of metabolic acidosis, which is caused by gain in a fixed acid or loss of bicarbonates and decreased pH? Metabolic acidosis is diagnosed when bicarbonates is less than 24. And possible causes include diabetic ketoacidosis and in case of methanol poisoning. Metabolic alkalosis is caused by loss of hydrogen as a fixed acid, which results in increase of bicarbonate and increased pH. And metabolic alkalosis is diagnosed with the bicarbonates level, it will be greater than 24. And possible causes include vomiting when there is a loss of hydrogen or diuretic abuse. So here you can see a summary on kidney excretion of hydrogen ions, and hydrogen is secreted into the tubular fluid in both in proximal convoluted tubule and collecting ducts. In proximal convoluted tubule, we have sodium hydrogen transporters, antiporters, which secrete hydrogen as they reabsorb sodium. And in collecting ducts at the apical membrane of some intercalated cells include proton pumps, hydrogen ATPases, that secrete hydrogen into the tubular fluid. So hydrogen secreted into the tubular fluid of the collecting ducts, that's the tubular lumen, they will be buffered by three mechanisms, either phosphates or ammonia or bicarbonate. So here you can see these examples. And these ions cannot diffuse back into the tubular cells, and they will be excreted in urine. So this is basically the hydrogen mechanisms of the hydrogen handling. And inside the cell mechanisms, they're pretty much the same to what you have seen in red blood cells, where you have the CO2 binding to water with the help of carbonic anhydrase, and carbonic acid will be formed, which is unstable, and it dissociates into hydrogen and bicarbonates. Bicarbonates could be removed back into the capillary in exchange of chloride ions. Thank you for your attention.